patient with BRAF mutant metastatic melanoma, there are many FDA-approved therapeutic options available for this patient. Because this patient has a BRAF V600 mutation, targeted therapies are certainly an option. At this time, the standard approach with targeted therapies is to use BRAF and MEK combination therapies as opposed to single-agent BRAF inhibitors. And FDA-approved options include the combination of dabrafenib and trametinib and vemurafenib and cobimetinib. In treatment-naive metastatic melanoma patients with a BRAF mutation, the expected clinical response rates with these agents are in the range of 70 to 75% with disease control rates of greater than 90%. The median progression-free survival on each of those combinations is approximately a year, and we're building up more and more data about the long-term outcomes with those therapies. In addition to targeted therapy, it's also very reasonable to consider first-line immune therapies in a patient like this. And based on randomized trials, really that's a decision between single-agent PD-1 therapy or combination immunotherapy with ipilimumab and nivolumab. Single-agent PD-1 therapy with either nivolumab or pembrolizumab has a response rate between 40 to 45% in treatment-naive metastatic melanoma patients. And notably, most of those responses are quite durable, with most responses lasting at least 2 years. The combination of ipilimumab and nivolumab has a response rate of close to 60%, and many of those responses appear to be quite durable. Interestingly, recent randomized clinical trial data from the Checkmate 067 study does suggest that 2-year overall survival with single-agent nivolumab and the ipi-nivo combination is actually very similar. So it's hard to tell at this point how to pick specifically between single-agent PD-1 therapy and the ipi-nivo combination in the frontline setting. So for this patient with BRAF mutant metastatic melanoma, treatment with a BRAF-MEK combination such as dabrafenib and trametinib is a very reasonable therapeutic option. Now, while overall we know that the median progression-free survival with dabrafenib and trametinib is approximately 1 year, it's clear that some patients have much better outcomes than that, while other patients have much worse outcomes than that. Recent studies that have looked retrospectively at large clinical trials with both BRAF-MEK combinations that are approved for use in this disease have identified a number of factors that predict whether patients will have better or worse outcomes. Particularly relevant to this patient, it's actually been demonstrated that patients who have a normal LDH and a low tumor burden can actually do exceptionally well with BRAF-MEK combination therapy. Indeed, those patients have a very high chance of achieving a complete response, and patients who achieve a complete response with dabrafenib and trametinib therapy have a 2-year survival rate that's actually close to 80%. So in this patient who's presenting with, again, what appears to be a very low burden of disease and a normal LDH, we would expect this patient to have a very high chance of an initial response, certainly even higher than the average response rate of 75%. And it's very likely that this response will be quite durable in this patient. Therefore, the treatment with BRAF and MEK combination therapy was a very reasonable choice in this patient. However, we do also know that this low serum LDH and low tumor burden potentially also predict very good outcomes with immune therapies as well. So again, this is a patient with a multitude of good treatment options, both in this setting and if treatments are needed subsequently. This is a patient with BRAF mutant metastatic melanoma who's been started on combination targeted therapy with dabrafenib and trametinib. And again, although the overwhelming majority of patients treated with this therapy in this clinical scenario will have not only a response but very good responses, it is true that many of these patients will eventually progress. What would be the treatment options at that time? There would actually be multiple treatment options available. Among FDA-approved treatment options, again, the primary options for this patient would be treatment with either single-agent PD-1 or the ipi-nivo combination therapy. Both of those therapies are known to work in BRAF mutant patients who are either treatment-naive or after progression on targeted therapies, and so they would remain very good treatment options for this patient even after prior treatment with targeted therapy with dabrafenib and trametinib. Certainly, patients like this are also good candidates for clinical trials, which should also be considered in that clinical setting.